Hello class, we're talking about antihypertensives here. We'll split into two sections. So this is the first part. Hypertension is defined as either sustained systolic blood pressure of greater than 140 or sustained diastolic blood pressure of greater than 90. Hypertension results from increased peripheral vascular arterial or smooth muscle tone, which leads to an increased arterial resistance and reduced capacitance of the venous system. In most cases, the cause of increased vascular tone is unknown. Elevated blood pressure is an extremely common disorder affecting approximately 15% of the population of the United States, 60 million people. Although many of these individuals have no symptom, chronic hypertension, either systolic or diastolic, can lead to cerebral vascular accidents like strokes, congestive heart failure, myocardial infarction, and renal damage. In recognition of the progressive nature of hypertension, hypertension is classified into four categories for the purpose of treatment management: normal, prehypertension, stage 1, and stage 2. Although hypertension may occur secondary to other disease processes, more than 90% of patients have essential hypertension, a disorder of unknown origin affecting blood pressure regulating mechanisms. A family history of hypertension increases the likelihood that an individual would develop higher than normal blood pressure and hypertensive disease. The incidence of essential hypertension is fourfold more frequent among blacks than among whites. It occurs more often among middle-aged male than among middle-aged female, and its prevalence increases with age and obesity. Arterial blood pressure is regulated within a narrow range to provide adequate perfusion of tissue without causing damage to the vascular system, particularly the arterial intima or the endothelium. Arterial blood pressure is directly proportional to cardiac output and peripheral vascular resistance. Cardiac output and peripheral resistance in turn are controlled mainly by two overlapping control mechanisms: the baroreflexes and the renin-angiotensin-aldosterone system. Most antihypertensive drugs lower blood pressure by reducing cardiac output and/or decreasing peripheral resistance. Baroreflexes act by changing the activity of the sympathetic nervous system. Therefore, they are responsible for the rapid moment-to-moment regulation of blood pressure. A fall in blood pressure causes pressure-sensitive neurons, baroreceptors in the aortic arch and carotid sinuses, to send fewer impulses to cardiovascular center in the spinal cord. This prompts a reflex response of increased sympathetic and decreased parasympathetic output to the heart and vasculature, resulting in vasoconstriction and increased cardiac output. These changes result in a compensatory rise in blood pressure. Lack of patient compliance is the most common reason for failure of antihypertensive therapy. The hypertensive patient is usually asymptomatic and is diagnosed by routine screening before the occurrence of overt and organ damage. Thus, therapy is generally directed at preventing future disease sequelae rather than relieving the patient's current discomfort. The adverse effects associated with hypertensive therapy may influence the patient more than the future benefits. For example, beta blockers can decrease libido and induce erectile dysfunction in males, particularly middle-aged and elderly men. This drug-induced sexual dysfunction may prompt the patient to discontinue therapy. Here's a clinical guideline for management of hypertension. Lifestyle modification does play a big role in terms of weight, in terms of diet. Diuretic can be used as first-line drug therapy for hypertension unless there are compelling reasons to choose another agent. Low-dose diuretic therapy is safe, inexpensive, and effective in preventing stroke, myocardial infarction, and congestive heart failure, all of which can cause mortality. All oral diuretic drugs are effective in treatment of hypertension, but the thiazides have found the most widespread use. The loop diuretic furosemide act promptly even in patients with poor renal function or who have not responded to thiazides or other diuretics. Amiloride and triamterene, inhibitors of epithelial sodium transport at the late distal and collective duct, as well as spironolactone, can reduce potassium loss in the urine. Beta blocker are currently recommended as first-line drug therapy for hypertension when concomitant disease is present, for example, in post-myocardial infarction patient or in patient with a previous myocardial infarction. The beta blocker reduce blood pressure primarily by decreasing cardiac output. They may also decrease sympathetic outflow from the central nervous system and inhibit the release of renin from the kidneys, thus decreasing the formation of angiotensin II and the secretion of aldosterone. The prototype beta blocker is propranolol, which acts at both beta-1 and beta-2 receptor. Selective blocker of beta-1 such as metoprolol and atenolol are among the most commonly prescribed beta blockers. The beta blockers may cause bradycardia and CNS effects such as fatigue, lethargy, insomnia, hallucination, and this drug can also cause hypotension. The beta blocker may decrease libido and cause impotence. The ACE inhibitor such as lisinopril are recommended when before first-line agent such as diuretic and beta blocker are contraindicated or ineffective, or if there are compelling reason to use them, such as in diabetes mellitus. The ACE inhibitor lowers blood pressure by reducing peripheral vascular resistance without reflexively increasing cardiac output rate or contractility. The drug blocks ACE that cleave angiotensin I to form the potent vasoconstrictor angiotensin II. Common side effects include dry cough, rash, fever, altered taste, hypotension, and hyperkalemia. The dry cough, which occurs in about 10% of patients, is thought to be due to increased level of bradykinin in the pulmonary tree. Angiotensin II receptor blocker are alternatives to the ACE inhibitor. A selective renin inhibitor, aliskiren, is available to treat hypertension. Aliskiren directly inhibits renin and thus acts earlier in the renin-angiotensin aldosterone system than do ACE inhibitor or ARBs and angiotensin receptor blockers. It lowers blood pressure about as effectively as ARB or ACE inhibitor and thiazides. It can be combined with other antihypertensives such as diuretic, ACE inhibitor, ARBs, and calcium channel blocker. Calcium channel blocker example are verapamil, diltiazem, and nifedipine. The intracellular concentration of calcium plays an important role in maintenance of tone of smooth muscle and in contraction of myocardium. Calcium channel blocker causes vascular smooth muscle to relax, dilating mainly arterioles. These agents are useful in treatment of hypertensive patients who also have asthma, diabetes, angina, and or peripheral vascular disease. Constipation occurs in approximately 10% of patients treated with verapamil. Dizziness, headache, and a feeling of fatigue caused by a decrease in blood pressure are more frequent with nifedipine, amlodipine. The alpha-2 agonists diminish the central adrenergic outflow, decreasing the firing rate of sympathetic nerves and the amount of norepinephrine release. Clonidine is used sparingly for the treatment of hypertension that has not responded adequately to treatment with 2 or more drugs. The direct-acting smooth muscle relaxants such as hydralazine and minoxidil have traditionally not used as primary drugs to treat hypertension. These vasodilators act by producing relaxation of vascular smooth muscle, which decreases resistance and therefore blood pressure. Hydralazine is used to treat moderately severe hypertension. It is almost always administered in combination with a beta blocker. Minoxidil also used with beta blocker and diuretic. Minoxidil is also used in the treatment of male pattern baldness. Hypertensive emergency is a rare but life-threatening situation in which the diastolic blood pressure is either greater than 150 mm mercury with systolic blood pressure greater than 210 in an otherwise healthy person or greater in an otherwise healthy person. Nitroprusside is administered intravenously and causes prompt vasodilation with reflex tachycardia. It is capable of reducing blood pressure in all patients regardless of cause of hypertension. Labetalol is both an alpha and a beta blocker and is given as an intravenous bolus infusion in hypertensive emergency. Phenoldiazepam is a peripheral dopamine 1 receptor agonist that is given as intravenous infusion. Nicardipine is a calcium channel blocker, can be given as an intravenous infusion. There are some predictable differences in response to hypertensive drug among patient groups, which can be summarized by the ABCD guidelines. For young and white patients, consider starting with an ACE inhibitor A or beta blocker B. For older and black patients, consider starting on a calcium channel blocker C or diuretic D. Avoid ACE inhibitor, angiotensin receptor blocker, and aliskiren in pregnant women because the drugs are fetotoxic. The goal antihypertensive therapy is to reduce cardiovascular and renal morbidity and mortality. Initial therapy with 2 antihypertensive drugs should be considered in patients with blood pressure that are more than 20/10 above the goal. The combination of a low dose of thiazide diuretic with a beta blocker, an ACE inhibitor, or an angiotensin receptor blocker has a synergistic effect controlling blood pressure in up to 85% of patients. Some of the available preparation in terms of combination are shown. That's it.